Transforming the Queen Elizabeth Hospital, Barbados' primary tertiary healthcare facility, is the ambitious goal set by CEO Neil Clark. Relatively new on the job, just 6 months into his tenure, he's steering the 60-year-old institution towards a new path. Mr. Clark outlines his 3-year vision to modernize the QEH. In this episode of In the Know, he discusses his plans to tackle challenges within the Accident and Emergency Department, enhance the hospital's overall efficiency and infrastructure, as well as digitize the healthcare facility. I'm Krystal Hoyte, and this is In the Know. Mr. Clark, thank you for joining me.
Thank you for inviting me.
Let's begin by talking about the future of healthcare at the Queen Elizabeth Hospital. As you chart the path forward with the QEH strategy 2025 to 2028, can you give us an overview of this plan? What is your vision for the Queen Elizabeth Hospital?
We need to modernise the healthcare here in Barbados, and this plan for the next 3 years starts us on that journey. Within the plan, we're looking at 5 main areas within the plan. One's healthcare delivery, so how we deliver healthcare services, making sure that they're safe, caring, responsive, efficient and clinically well led. We look at the infrastructure and the equipment within the building. We look at the workforce and how we can support and develop the workforce. We look at how we're financially sustainable, so the financing of the hospital. And then we look at IT and the health information system.
One of the key priorities outlined in the strategy is improving service delivery. A common complaint from the public, however, remains long waiting times, especially in the Accident and Emergency Department. Could you walk us through the intake process? Where do the bottlenecks typically occur, and what steps are being taken to reduce these waiting times?
So it's important to understand that an A&E department in any healthcare system will be the bottleneck for pressures across the whole of the health system. It's where people will come to when they think that they're an emergency need. So they can't plan that attendance, they have to just arrive as and when they have the particular needs. And there's a number of things that we have to think about for an A&E. Number one is, why are people coming to A&E in the first place? What can we do to prevent them coming? How can we keep people well? What's the role of the individuals in keeping themselves well? What's the role of public health in giving them the correct advice on how to stay well? What's the role of primary healthcare and the polyclinics in doing regular checkups on the patients? Making sure that screening and immunisations and good health well-being is being maintained. So if we can stop people coming to the A&E department who don't need to come to the A&E department, we can reduce the demand on that particular system. A number of people will come because they've had a preventable illness that could have been managed better, resulting in them not having to attend A&E. But a number of people will come and it will be unavoidable, and they'll have to come to the A&E department. When they arrive at the A&E department, we'll triage everybody to assess how critically ill are the people. And that triage is taken place by the nurses, and they will categorise whether they need immediate treatment or whether they can wait a little bit longer. Because we have to make sure that we're giving those who need immediate life-saving treatment, that treatment as soon as possible. Following triage, they will be seen by an A&E doctor, and that will be in line with the triage category that the patient was identified with. Following being seen by the A&E doctor, they may require diagnostics or pathology. And so there's a link then between the A&E department and the diagnostics and the laboratory departments, and ensuring that we can get timely results back to the doctors so they can make informed decisions on the patient's treatment. Following that, there may be a discharge from the A&E department, or they may be admitted into the hospital. If they're to be admitted into the hospital, the receiving doctor will have to review the patient and confirm that the patient needs that admission and where the patient would be admitted to. That leads to a second challenge then about how the beds are made available to the patients. A patient will go into a bed if there's a bed available, and ideally we want to get the patients in the right bed. I want a medical patient in a medical bed, a surgical patient in a surgical bed. Often, if we're very busy, the beds can become a challenge, and that can back up then into the A&E department, where patients are not moving through the A&E department onto the beds. There's a number of things we can do in the hospital to alleviate that, and that includes better discharge planning from arrival. So as soon as a patient arrives into a hospital bed, we should be trying to think straight away, what's the care plan for this patient? What have we admitted them for? What do we plan to do to them, and what do we need to happen next? We should make sure that that process happens as swiftly as possible, and then we move to a safe and timely discharge as soon as possible. So people don't stay in beds any longer than they need to, so we can release those beds to other patients who need them. Releasing a patient from the hospital is also rather complex. Some patients will go straight home, and that's quite simple. We can just discharge them from the hospital and they will go home. Some people will need an element of support before they go home, and they can be transferred to a transitional care department or unit or transitional care team and then go home. Some people will need longer term support before they can go home, and that might be either healthcare long-term support or social care long-term support. So we have a discharge team, a social care team, who are trying to identify as patients are leaving the hospital, what kind of support will they need and where will that support be made available from. If we had timely access to the services when people are being discharged, then we could move the people out of the system faster. So we work closely with the community providers and the private providers to move those people who need supported discharge out of the hospital in a timely manner. So if any of those elements that I just described back up, be that there's no availability in the community to support somebody following discharge, there's a delay in getting pathology or diagnostics, there's a delay in getting a bed, a delay in getting a specialist opinion, a delay in getting the A&E doctor to see the patient, any of those elements will result in a delay in the A&E department. So unfortunately for A&E, it's not there's one thing to fix, there's a whole myriad of things to fix, and you have to line them all up together so that they will all function together at the right time. What we do to do that is we monitor the number of patients coming through the department, and we monitor where those delays are. This hospital's got a challenge. Our data's poor at the moment, so trying to track in real time where patients are or where the delays are is a challenge. But we do our best to track that, and we identify a number of KPIs, a number of triggers as to when we can see the systems getting hot and where it's getting hot. If the delay is with pathology or diagnostics, I don't need to be running around addressing challenges on the beds. If the delay is with A&E triage, I don't need to be escalating pathology or diagnostics. So we need to understand then for each of those stages of the patient's journey through the system, where is the delay occurring? How can I identify that delay as early as possible? And then what actions can we take to address that delay? And those actions and triggers are dependent on each of those different stages within the treatment of the patient. So it's a complex process, but it's one that I've managed a number of times in a number of places before, and it's one I'm confident we can manage here.
And as you mentioned beds, how many beds do you have?
There's about 550 beds in total, but not all beds are available to all patients. So for example, I can't put an adult in a paediatric bed. I wouldn't put a non-acutely ill patient into an intensive care bed. So whilst we have a number of different bed stocks available, there's 550 in total. We're getting more physical beds. So we have a number of spaces where I could place a bed, but I don't physically have a bed to place at the moment. So we've got an order out at the moment for 50 more beds, and those beds are on the way to us. And there'll be further beds coming next year from the additional $130 million of CapEx expenditure that has been approved by the government.
We often hear of a number of elderly persons being abandoned at the QEH. Is this impacting the number of beds?
Yes. So I'm not sure whether they're abandoned or the families are not supported in enabling to get the patients out. So I hear the word abandoned. I've heard that word used here, but sometimes I think maybe the families don't have the right support to help them get their family member back home. And if we could give better support to the families to receive their family members back, then that might be helpful. So for example, if they have to go out to work and the family member's being brought back home, they might be nervous of what will happen to their family member when they're at work. So there are some issues we might want to address in how we support families in receiving the patients back home. And we need to work closely with the community care providers and the social care providers to support that timely discharge back home. We do have a number, which tends to average around 30 to 40 patients who no longer need to be in an acute bed, and they could be managed somewhere else. We do have to manage those patients within the beds, and that's 40 beds that I've not got available to the A&E department. And how we manage those, I plan to change in the future. Currently, those patients are spread across the beds in the hospital, and I plan to cohort them into one location so they can be managed better by a social support team and discharge team who are looking after their care and progressing them being discharged. Not all of those would be able to go home. Some might need long-term care, but if we can manage those in one location and keep the acute beds available for the acute patients, that will be a good advantage for us. It's really important that we work to get the right patients in the right beds. The last thing we want to have is a medical team searching around the whole of the hospital for the medical patients. So we need to make sure that the medical patients are in the medical beds and the surgical patients are in the surgical beds. And to do that, we need to review our bed numbers. And not so much the numbers of total numbers that we've got, but how the beds are allocated to the different teams. And that's a piece of work that we're starting and called the Bed Optimization Programme, where we'll have a review of how many beds are required for medicine, how many beds are required for surgery, which teams will be supporting which wards. There's a number of benefits. Not only is the doctor then not searching around the hospital for his patients, the relationship between the doctors and the nurses becomes stronger because they get to know each other. And if a medical doctors are going onto a surgical ward looking for his patient, and he doesn't normally work with that nursing team, the relationship's not as strong. And a good relationship, good communication is essential to good patient care.
This is a 3-year strategy. 6 months ago, when you became CEO, you highlighted A&E as being a priority area. So I guess the question now is timeline. When can Barbadians expect service at A&E to improve?
The service for A&E will be improving in 2025, absolutely. And that's already started now. So already we have additional nurses being put into the A&E department, and we're recruiting for additional doctors. So additional staff will come into the A&E department. Already we've brought the CT scanning machine into the A&E department, and that's being commissioned as we speak and should be available by the end of this year to go live. That will mean, therefore, patients don't have to travel as far for the diagnostics, and we're not waiting for patients to be picked up by the orderlies, transferred down to the radiology department, have the diagnostics and brought back. So that's already in the system and being managed as we speak. It's being brought online. Already we've started to develop what we call the escalation plan. And this is the important element of identifying, is there a pressure somewhere in the system, and where is that pressure? And how can we identify that pressure early on rather than after the event? There's no point in saying there's 60 people in the A&E, we're in trouble, we've got too many people here. I need to be identifying how many are arriving at the A&E. So as they arrive and I can see the numbers are higher than normal, we can start to take earlier interventions. So already there's a detailed plan being developed and supported by all the different departments in the hospital to work out how can we manage the escalation flows, because as we said before, an A&E delay is not necessarily as a result of something that's happening in the A&E department. It could be something happening on the beds, on the wards. It could be something happening outside the hospital, or it could be something happening in the pathology or diagnostic departments. So we've got a draft document already produced, which identifies for each department what their triggers are, how they should be, what their normal operating pattern should look like, when that's getting busier, and we can escalate them from green to yellow to amber to red. And each of those different escalation steps comes along with a suite of different actions to be taken. That plan, I said, is about 80% complete. It'll be probably completed within the next month. It'll take a little bit of time of sensitizing that and making sure people understand how to use it and what the individual responsibilities are. There are action cards for different individuals, and they'll have to be trained and understand what the expectations are for everybody to help that flow smoothly. Another thing we've got coming is the service improvement managers. And these will be managers who will be trained in service improvement techniques. And that's understanding patient flows and bottlenecks and understanding how we address those and how we facilitate change through those. There are 4 of those joining us. The adverts are actually in the newspaper, I think, at this very moment. We've done internal recruitment for some of the posts and external recruitment for some of the additional posts. We're looking forward to getting those into place and training those individuals up. And they will be the individuals then who can manage the patient flows. Their whole role is about waiting times and efficiencies. At the moment, we're reliant on doctors and nurses to take their time out of doing their clinical duties to actually write the papers and collect the data and provide the reports. That will be done by the service improvement managers, supported and led by those clinical leads but they will be able to do the legwork of finding out what's the challenge and really get into the nitty-gritty of how do we take this forward.
And I'm glad you mentioned staff. Would you say that QEH is adequately staffed, or are there any key shortages that need immediate attention, both clinical and administrative staff?
We have a number of staffing challenges that relate to recruitment. So I think staffing-wise, we've just been given nearly 300 new posts, which is an incredible amount of additional investment into the hospital, nearly 10% of our staffing, and that will address most of our needs. The challenge now will be finding the people for those posts. We know that internally within Barbados, we've got a limited pool of people to recruit from, so we have to go external at some points to recruit staff. That can be a timely exercise. So we're working on how we can better recruit internally, how we can in the future ensure we have a pipeline of students choosing to do the right careers that will lead into healthcare. So we have the nurses, allied health professionals and doctors of the future in the pipeline, so we don't have to do external recruitment. But if we have to do external recruitment, how we can do that a little bit better and slicker. Already, we've just published on our website, there's a new page now for Come Join Us, and you can see all the jobs that are being advertised externally for people to come and join us with. We're hopeful that with our new strategy for the recruitment, the way we're identifying recruitment agents, the way we're using contacts that we've got to share the information of the post available, that will be successful in recruiting the majority of those posts in the next few months.
How many additional doctors and nurses are required to meet the current demands of the hospital?
I think with the nursing, with the additional nurses we've got, we'll have the right numbers. We could always ask for more, but I think it's really about being efficient with what we've got and managing the resources what we've got well. As I mentioned before, that if we work towards managing the inpatients flow better and get faster, safely and timely discharges, then I won't need as many beds. And then I can consolidate the nurses we've got onto the existing patients.
How many nurses do you currently have?
We're working to a ratio of about 1 nurse to 5 patients, which is quite a good ratio. In the NHS, the UK, they can have a ratio of 1 to 6. So we've got quite a good ratio of nurses now. So the additional nurses are supported by the ones we brought from Ghana recently. The additional nurses have kind of really helped get some stabilisation onto the wards and to the A&E department. For the number of doctors, slightly more complex, and we still need to really understand exactly what are the challenges we've got with the data is understanding what's the waiting list and the waiting times that we've got. It's very hard to see when we're on a manual system how many patients are waiting for services in total. And I'm very much into identifying what's the demand for services. If a waiting list was static, i.e. it wasn't getting larger or it wasn't getting smaller, I can probably see what the real demand is for patients. And then we can work out mathematically how many doctors would we need to manage that demand. It's a mathematical calculation. Different things take different times. We know how long an outpatient appointment for psychiatry might take, which might be up to 50 minutes, compared to an outpatient appointment for maybe orthopedics, which might be 20 minutes. So mathematically, we can work out on the numbers how many we'll need. So that piece of work still to be done to get the true picture of supply demand on the numbers of the doctors within the system. We clearly know we've got long waits in some areas. Some of those waiting times are coming down. Some of that's created by challenges in relation to scheduling, and some of that's created by challenges in relating to how often we keep bringing patients back, and the ability to transfer a patient safely from acute care back to primary care with a care plan given to the family medicine physician. So there's a lot of work still to be done on how we push through the flow of what I call the elective patients, the outpatients and the inpatients who are coming with planned appointments, how we manage those through the system, how we monitor and manage their waiting lists to reduce those waiting lists, and how we allocate space to those different specialties. So, for example, if I had a longer waiting list in one particular specialty, could I allocate more outpatient clinic space to that specialty for a short period of time to allow them to catch up? Can I shift them from outpatients to theatres or theatres to outpatients? So planning how we utilise the medical resource, again, is a complex process, but it's something that we can do and something that will be much easier to do when we get the health information system.
Still on staff, there was a concern over the long working hours, especially among junior doctors. The culture of 32-hour shifts every 4 days was brought to the fore in March last year, predating your arrival, but how has management addressed these concerns, given that sleep-deprived doctors can compromise healthcare?
I completely agree. And so having a doctor who's on duty all day, working on night on call, but the reality of being on call is he's attending to patients in A&E all night. And if he's not doing that, then he's asleep, and therefore the patient's not being treated in the A&E, which is what we don't want anyway. And then being on duty the next day, I completely agree. That is, in my view, not the best way to manage the resources that we've got. I've had discussions already with some of the junior doctors about this, and we're happy to explore alternative ways of managing the doctor hours. We've got a project called the 24/7 project, which sounds strange because the hospital's already open 24 hours a day, 7 days a week, but not all the services are aligned with that. And within this 24/7 project, we want to identify, and we've started this already, we've already identified the current contractual requirements for the different staff groups. So who's working Monday to Friday, 8 to 5, and who needs to work what hours in the future. So already we have a number of staff who have a contract where they're working Monday to Friday, 8 till 5 or 8 till 4, but often have to work evenings and weekends. And what we want to do is review the whole of the structure of the working hours and the contracts to address that. We plan to do that in 3 different areas. We'll do that for the non-clinical staff, so for the engineers, the orderlies, the security teams, etc. We'll do that for the nursing and the allied health professionals, and then we'll do that for the medical staff and the doctors. When we do that for the medical staff and the doctors, we'll clearly be reviewing how we manage the out of hours and how we manage the weekends. And what the aim of the whole exercise is to say, we've got a hospital that's functioning in many areas 7 days a week, 24 hours a day. What services and what support do we need for each of those areas 24/7? What support do we need just 7 days a week, 18 hours a day, 24 hours a day, or just 5 days a week? So that exercise has started already. We've already started to produce the framework of how we're going to take this forward. But the way I do these things, the principle of this is that I'm going to share the problem. I have the ideas of how we can solve this. I've seen how we've solved it in other places. I have ideas, but I prefer to share the problem. And so here's a problem, and we'll have facilitated workshops with facilitators to identify, well, what's the options for addressing this? Because there's always going to be more than one option. My idea might not be the best idea for Barbados. And I'm very clear that if we can get an idea at the staff support, it's going to be much easier to implement than me trying to force something down them that they don't support. So I think it's a real piece of work to be done in the first quarter of next year to start those consultations and those negotiations of what would a 24/7 hospital contract look like for each of those 3 different staff groups.
Coming up, we're talking about some of the challenges outside of the A&E department. Stay with us. Mr. Clark, while A&E is often in the spotlight, we know it's just one part of the hospital. What are some of the other challenges the hospital faces in terms of service delivery, and how do you plan to address them under the new strategy?
I think we've identified 128 initiatives in the new strategy to be addressed. So there are a significant number of challenges that we need to address, but agreeing that the A&E is probably one of the most publicly visible ones, although that takes into account of a number of the other challenges that we have, and addressing some of the other challenges will also support then the addressing of the A&E challenges. So challenges we have challenges around procurement and how we need to ensure that we have equipment available for the clinicians at the right place and the right time. We touched on just before about some of the challenges in relation to managing outpatient waiting times and access to inpatients and theatres. We've got challenges, I think, in some areas in relation to attitude and how we respond to each other as staff members and how we respond to the public. And I say that because obviously we do receive complaints. And I always point out that we're happy to receive complaints because complaints allow me to see where there's a challenge that we can go and have a look at something I need to do and change. But the number of complaints we receive is a very small fraction. I think it's 0.02% of all the patient contacts we have. I've no doubt that there may be more complaints that we don't see, that people don't actually take the time to articulate to us. And we do encourage them to put them in because we do want to understand and triangulate if complaints sit around the same area. A number of those complaints are about attitude and about how the patients were treated. So the vast majority of the staff, I have no doubt, are providing excellent care to the patients that they see. That's the vast majority. But there will be a number of staff that maybe who are not. And we clearly need to address that. Because when a patient's here, they're vulnerable and they're afraid. And it's our job to be caring and compassionate and ensure that they get the full support and the best communication that they can have. So we have to work on how we manage to ensure that everywhere and every patient gets that best possible care and support. So again, there's a number of areas, 128 initiatives altogether. One of the biggest ones, and I know you would probably want me to touch on this, would be the health information system. This will give us a spine of capturing information that we can then use to make informed decisions and real-time decisions. It's a really important one for us. Reviewing theatre utilisations, how we manage the theatres. We're back up at the moment to 9 theatres, which is great news. We plan to go to 12 theatres. We have a plan in action as we speak already to review the roof on the Lions Eye Care Centre and get that roof fixed, which will bring into effect 3 more theatres. So we're currently in the early stages of the procurement for the quality surveyor and the architect who will be doing the design for the scope of services to fix those. We've already got the equipment lined up to come in to kind of fix out those theatres, and that would take us to 12 theatres. So it's again significantly increasing our capacity to reduce those waiting times.
Speaking of equipment, what critical equipment needs replacing or purchasing to better serve the needs of patients?
I said earlier, we've got $130 million coming of capital expenditure. The vast majority of that is on equipment, and that's it. And that will produce 400 different items of equipment that we're going to be purchasing to come in, and that's across a range of different specialties within the hospital. So there's a lot of equipment coming over the next 12 months into the hospital to replace a lot of the old equipment. And that's really exciting because that means then we'll be getting rid of some of the old equipment and replenishing it with new equipment. And some of the time challenges we've had where equipment breaks, that should reduce that because some of this equipment's beyond life date. Some of it's significantly beyond life date. So this is a very exciting time for us with the additional staff and the additional equipment coming in. Really exciting times for the QEH.
And as you mentioned procurement, are there challenges in this regard as it relates to medical supplies? For example, it's no secret that on more than one occasion this year, the QEH ran out of gauze. What steps are being taken to ensure that the hospital has adequate stock of essential supplies, and what is being done to streamline the procurement process?
So the procurement process has indeed been a challenge. And I think for many islands, procurement of healthcare supplies is a challenge because of the time it can take to replenish your stocks. And if the stocks are coming from abroad and you've got a 6-week lead in time for them getting shipped, we have to plan better for what we need. So part of the plans for the procurement is the implementation of the inventory management system, which is being rolled out as we speak. And in fact, it's rolled out in all places as of today. All the departments have got the inventory management system. Implementing and embedding that will take a bit more time. Identifying what we call PAR levels, stock levels that we need to maintain will take a little bit more time. So there's still work to be done on the procurement before we get to the stage where we can say comfortably we should not stock out of anything. So once we've got the system up and running correctly and we've identified all the supplies that we need, we've identified what the usage rate is of those supplies, and we've identified where those supplies come from and how long they take to ship, and then we've identified what stock we're going to keep at PAR level, so how many weeks or months supply we're going to keep, and ideally that would be 2 to 3 months supply of all our supplies, but managing expiry dates. When we've got that system in place, then we shouldn't be seeing stock out. But in my first 6 months here, I saw too many stock outs, and I'm looking very closely at our procurement process.
Mr. Clark, the Queen Elizabeth Hospital was built more than 60 years ago, and while it has undergone some changes over the years, it's still an aging building. What plans are in place to address the infrastructure challenges, particularly in terms of maintenance and even perhaps modernization?
So there's a plan to review the Enmore site across the road and take over the laboratory and the oncology centre and some additional clinical space and office space. There's a plan to refurbish the Lions Eye Care Roof Centre, as we mentioned earlier, and bring on board more theatres. We've just actually brought into the back of the hospital now an additional water tank. So we have more water resilience coming hurricane. That's really needed, because I think when we went into the last hurricane, probably one of my bigger concerns that we have 3 days water. So there's a real challenge. That would be a difficult situation to manage. So the second tank now, which is an even bigger tank, gives more resilience for us during hurricanes. We're forever reviewing the infrastructure. And I get a monthly report. When I first came here, I asked for a monthly report on all what I call critical infrastructure and critical plant and critical equipment. When is it serviced, and how can I be assured that it's safe? Because the last thing we would want to do is have some critical plant failing, which may cause harm to patients, or critical equipment failing, which may cause harm to patients. We've got a detailed list now of all the identified critical plant and equipment, and a maintenance schedule against that, and a tracking report which we receive and take to the committee, the board, each month, saying here's all the process, here's all the progress against all those areas. Part of the funds for the capital expenditure will replace some of those areas, and part of it will do some works, minor works, within the hospital. But you're absolutely right, it is a 60-year-old building, and it's a challenge to maintain, and I think our engineers do an amazing job of maintaining a building of this age.
Beyond maintenance, there have been recurring complaints about environmental concerns at QEH, such as mold, rodents, and roaches. The unions earlier this year highlighted a rat infestation in several departments, including the kitchen. What steps have been taken to address these issues?
There is an environmental health plan that's applied in the organisation. I'm not personally aware of the rodents challenge. I'm sure there will be rodents around the area. We're very close to a river, and there are rodents within Barbados, so I'm sure there will be. But I've not heard personally that there's rodents in the hospital or in particular areas, or there's a particular challenge. I have heard that there's a challenge of mould, and that is a concern for us. So a number of areas have got challenges with mould. Each time we identify an area that's got a challenge with mould, we have to look at how we keep our staff safe, and we immediately go to investigate that. We will bring in quality checks to assess whether we're going to cause harm to the staff who are in the areas. And if that's the case, we will work to how we remove, clean, and move the staffing to temporary locations whilst we address that. And we've had to do that on a number of occasions whilst I've been here. So that's an ongoing challenge, is managing the mould within the hospital. And again, that's partly because it's a 60-year-old building with air conditioning flows that are old. And as much as we maintain and manage those, there's always going to be a challenge, I suspect, with mould that we've got to have that ongoing battle with. But each time we identify where the mould is, we will take action to address that. And we've got an ongoing maintenance programme and cleaning programme which tries to prevent that in the first place.
Mr. Clark, as we look to the future, digitization is transforming healthcare across the world. What steps are being taken by QEH to incorporate digital tools into patient care and hospital management?
Well, as you will know, we're out for procurement for a health information system. That health information system will digitize the medical record notes that we have now. Rather than being on paper, they will be transferred onto the electronic system, and that will allow doctors to see information in real time. That will be, again, substantially support patient flow in the A&E department, not having to search for notes or not having notes available. They can immediately see the patient's notes, and they can immediately see what's been happening to the patient recently, and see whether there's any linkages to their admission in A&E with anything that's been happening to them recently. That information will also then provide us with valuable information about activity and about challenges and about those bottlenecks. It will also enable at some point the public to access their own health records directly into the system using a patient portal or a patient wallet, and they can see their health records and they can manage and book their own appointments within the system. So I think this is going to be a very exciting time as we move into digitisation of the Queen Elizabeth Hospital. It's well overdue. And I think the benefits it brings, I don't think many of the staff here will realise how many benefits this can bring by having that brought into place for their individual departments. The biggest challenge for the health information system probably won't be identifying and implementing the technical solution. it will be managing the change and working alongside the staff groups to be able to understand how this benefits them. We've worked very closely with the staff groups already as we've been developing this. There's been an extensive consultation with the staff groups. Each department's been involved in identifying what its needs are from a health information system. Each department that's got IT already has assessed whether the IT will transfer into the new system or will link to the new system and maintain what they've currently got. So there's a very detailed program about how we implement the system, and a lot of challenges will be there in how we support the staff in transiting from a manual-based paper system onto a technologically advanced health information system.
It's impossible to speak about digitization and not patient data security. How is QEH ensuring that patient data is kept secure and confidential? What measures are in place to prevent cyber threats, data breaches, or unauthorized access to sensitive patient information?
So there was a cyber attack here at the QEH before I arrived. I'm aware of that. There was recommendations put forward following that cyber attack. All those recommendations were implemented. I'm unable to tell you what the recommendations are because that would be supporting anybody who wanted to work out how to get beyond those recommendations. Part of the strategy does include identifying a cybersecurity consultant to give us additional advice. And we work very closely with the Ministry of Information, Science and Technology to get their support on cybersecurity of the government healthcare records. So there's a lot of work being done on that. One of the biggest threats, of course, to healthcare data, and any data for that matter, isn't the technology of the cyber attack, it's the human beings who allow that cyber attack to take place. So already we're doing exercises where we're training our staff to recognise and understand what's called a phishing email. An email that's come to you unsolicited, suggesting that if you click on this link, there's going to be some benefit for you or something interesting will happen. So already we've put into place a number of exercises to try and engage our staff in understanding that how easy it can be to fall prey to one of those phishing exercises. Some of them are very clever. Some of them have very good names and seem quite realistic, but we've got to train our staff to make sure that they don't allow that to happen. When we have the health information system, there will be a backup stored. So there'll be a real set of information in the cloud, protected by cloud cybersecurity tools and technologies, and a backup actually on site, also protected by cybersecurity technologies.
And finally, I want to talk about financing. While healthcare is often perceived as free by the public, we know that providing services at QEH comes with significant costs. Could you give us some insight into what it actually costs to run QEH on a yearly basis? And how is the hospital managing its budget and resources to ensure it can continue to provide quality care while staying financially sustainable?
So I think the phrase that healthcare is free is not correct, because everybody who pays their taxes and their health levies is paying for their healthcare. So I hear people say your healthcare is free, but you're actually paying for your healthcare. And because you're paying for your healthcare, we've got a duty to make sure that the healthcare we give you value for your money. You're actually paying for my salary, and you're paying for the Queen Elizabeth Hospital to operate. So we've got to ensure, therefore, then we're publicly accountable to how we spend that money. The budget for the Queen Elizabeth Hospital is in the region of 250 million. So that's a big budget. The vast majority of that budget goes on staff. So a vast majority of our cost is staff, followed by drugs and medical supplies. We have to develop better systems to be able to capture how that budget is cascaded down to individual departments, because I want individual departments to have their own budget statements. Currently, that's not possible. We're upgrading our finance IT systems to enable that, so individual departments can be accountable for their individual spends. I think that's really important that we cascade down to the department so they can see what their individual spends are. I think another important thing that we need to do is be able to cost the service accurately. So whilst we might know what the cost to run the hospital is, how do we know what the cost of an individual patient contact was? And I think we need to develop better systems also to be able to say the cost of the A&E treatment was X, the cost of that orthopaedic operation was Y. Now we can put notional costs against that, which we already have, and there's a national price list for the QEH for private patients coming here. But I think a true costing is different than a price. And I think we need to get into what the true costing is of each of the services. And that will help us then again understand if this is the cost and this is the price, how we can better ensure that we're getting financial sustainability and value for money. In addition to the budget that we receive from the taxpayers and the government, we also raise our own funds. We raise a number of funds of our own. And we also work very closely with philanthropy, where we receive other donations, which is normally equipment in the lines of equipment. But financial sustainability and value for money, I think, are really important. And I think more discussions will be had over the coming years about how can we move from a system of having maybe a block budget. How can we move to a system which maybe rewards quality of healthcare and numbers of activity of healthcare.
Final words to the public?
I want to say to Barbadians that I do hope, and I know the strategy conversation has been going on for some time, and I kept saying to my communications lead, whilst I know it's really important to speak to the public about what we're doing, it's really important to get on and do it. And words are just words. And what I really want to focus on in the next year is the doing, making it happen, how we transform these words into real actions and real outcomes. So when we're having these discussions next year at the same time, we're not talking about what we're going to do, we're talking about what we did do. So my message to the public in Barbados, I think we've got a strong plan. I think we've got a strong team, and I think we're all ready for this change. It's not going to be easy, and it's not a straight line, but we do have a roadmap to how we can improve this hospital. And I do think absolutely 100% that the staff and the teams here are ready for that change, and we're going to go through and make these changes for them. My vision is by 2028, which I know is a long way away, and we clearly need to see changes happening in 2025, but by 2028, I would love nothing more than for the public and the staff at the QEH to have the pride in this hospital that they should have, because it's your only hospital, it's your major tertiary care healthcare centre, and we should be doing an amazing service for the residents of Barbados, and really we should be the envy of the Caribbean. So lots of things to be done, and maybe it's time for the strategy is nearly completed. We've done the consultations. We plan to publish that in January, following our next board meeting in January. We'll publish the strategy, and then let's get down to business and let's make this happen.
Mr. Clark, thank you for making the time.
Thank you.
And thank you for joining me. This is our final episode for 2024. It's been my pleasure keeping you in the know these last few months. As we take a much needed break, my team and I wish you the best this holiday season, and we will see you in 2025.